All right, good afternoon and evening again, everyone. Welcome to the American Academy of Emergency Medicine Critical Care Medicine section's Pathways to Critical Care webinar series. My name is Matthew Carvey. I'm currently in Cleveland, Ohio, starting as an intern at Metro Health in Cleveland Clinic. And it is my pleasure to also serve as the AAEM RSA representative to the Critical Care Medicine section as well. On behalf of the CCMS, we are definitely delighted for you guys to join us for another piece of the critical care series, a deep dive into the various critical care fellowships. So I'm just going to stop sharing screen here. So just an FYI, today's webinar is going to be recorded. You guys have just seen that, and it's going to be uploaded to the CCMS's webpage within 48 hours, or for anyone who would like to view it at that time. Okay, so please invite your colleagues or anyone who wasn't unable to join us today, and hopefully they can watch it at that point. Okay, please use the Q&A box or the chat box if you'd like to ask a question during the actual talk itself. But please do keep yourselves muted until the end. We'll have time for questions at the end as well, okay? But definitely encourage the participation, and we'll definitely reserve time at the end for it, okay? So if there's no questions to really get this started, I'm just gonna go ahead and introduce each of our speakers really quickly here, okay? We are currently missing a couple of our speakers. Hopefully they can join us in a little bit. But it's my pleasure to introduce first and foremost, Dr. Hines, who is going to be representing our surgical critical care side. Dr. Chukwuanu, who's going to be representing the anesthesia critical care side. Dr. Evie Marcolini, who's going to represent the neurosurgical critical care side. And then Dr. Bracey, who is going to be representing the resuscitation side. And last but not least, Dr. Gordon, who is also our chair for the CCMS, who is going to be representing the critical care medicine side. Okay, so again, please keep yourselves on mute while we're doing this webinar. And if you have any questions, please just put them into the chat box. Okay, so I'm just going to get started now. Hopefully we can keep this on time. My whole plan for this is going to be to give each of the subspecialties 10 to 15 minutes to really present their piece. And we have a couple questions that we really want to ask them so that everyone on the webinar and everyone who is watching this can get a really good idea of what each subspecialty is. Okay, and hopefully if your interest lies in that area of critical care after you're finished an emergency medicine residency, then you can start delving into that as well. Okay, so again, my pleasure to have all of these subspecialties here. It's rare to get everyone in one place at the same time. So we'll go ahead and get started, okay? So I'm going to end up starting with, we'll start with Dr. Hines here, okay? Dr. Hines, do you want to give a quick wave to the camera?
Hello.
Perfect. So Dr. Hines, just let me read off your very descriptive I guess, setting here. So you're currently an assistant professor of emergency medicine and surgery, and you practice clinically within the trauma practice, in addition to being a critical care intensivist covering the TSICU, Neuro ICU, MICU, CTV ICU, and your hobby is a pandemic Pelotoner. I love it. That's awesome. So Dr. Hines, I just got a couple questions that we're going to throw your way, and then if you have anything else that you want to go on a tangent on, by all means, we'd love to hear it, okay? So first and foremost, what is surgical critical care? Like, what does that mean to you and where you practice?
So surgical critical care is about taking care of patients who understand they either come in with bad, profound comorbidities and end up having to undergo an operation that then you bring them through the acute resuscitation phase, de-resuscitation phase, due to the surgical illness, or that comes in with a traumatic injury that requires close monitoring in the intensive care unit. It's a fairly, it's kind of unique in that you take care of, you get to take care of the young people, but you also get to take care of the old people. And with a lot of the people also being kind of on the side if you have a higher amount of trauma patients in your surgical critical care unit.
Okay, no, that's great. And so where do you currently practice right now, and why did you choose that area?
I practice at the University of New Mexico because they were actually open. They're about one out of 4 or 5 institutions nationally that are open to the idea of an emergency medicine actually emergency medicine physician practicing within the trauma practice. And so since that was one of the biggest reasons as to why I went into critical care, that is what kind of like me to the University of New Mexico. It's also one of the biggest, or actually is the largest emergency medicine critical care group nationally. We have 14, I think, EM critical care hires at our institution.
Wow.
And
no, that's great. Yeah, I think it's a very interesting subspecialty of critical care. And it's really interesting because this is such a big and up and coming field for, residents in emergency medicine to start considering, especially with anesthesia and resuscitation coming in as well. But I'm also curious for, the residents that are considering surgical critical care, who fits best into the specialty? Like who do you look at and you're like, oh yeah, you would fit really well into surgical critical care?
I would say that if you like go through your trauma rotations or your surgical critical care rotations, and if you really just drive with the team, then that's a good indication. Like I always, surgeons, I like them quite a bit. They're usually short and to the point, and that didn't bother me. And I felt with them. I also liked, again, the being able to handle the young and kind of the younger patient population with less, oftentimes less comorbidities, and so oftentimes we're able, not always, but oftentimes we're able to get them in the unit and then out of the unit 20, 40, 60, 90 days in the intensive care unit. And so I think those are things that make a strong applicant. And then otherwise, it's just the normal things that make a good, strong EM critical care applicant, just wanting to take care of sick people, wanting to be mobile, working upstairs and downstairs, being good at resuscitation and attention to detail are all important things as an emergency medicine critical care physician.
Yeah, absolutely. No, that sounds really good. And so for, I guess, my last question would be, what is your favorite part of the surgical critical care specialty, or what's your favorite part of the area that you practice in right now?
Again, I actually end up covering all 4 different fields of the ICUs, whether it's the cardiothoracic ICU or the neurocritical care unit, or what brought me and surgery critical care between those 2 backgrounds. And what ultimately led me into the surgical critical care pathway was the trauma background. It's a fairly unique background, but we have a lot of graduates who sit there and gone out to do a lot of different various things. Whether it's we have a lot of people in like leadership positions, like my boss, John Marinero. He's the critical care divisional chief. You have Joe Schreiber as well. You also have people like working again, like within the trauma practice. They do that at St. Luke's. Miami's working at it. Houston is they have an EM critical care physician at Houston who also does it. In addition to, you also have researchers who sat there and kind of gone through the field, like Cindy Husso out at University of Michigan. She's a pretty big researcher who actually does now cardiac arrest research. So it's a pretty cool pathway, I think, that you end up having a lot of different opportunities. Then there's a couple of other like chairs too, which I think is pretty cool and unique. Brendan Carr and Evie and Maria Ellie are the 2 chairs that are surgical critical care pathway based.
Okay. No, that sounds great. And do you feel like the kind of specialty has kind of expanded over time, or is it kind of just remained kind of stagnant? Do you find us like more expansive now?
Yeah, and I find it interesting to see how everyone has kind of gone off into their own niche. So like I kind of talked about more about the academics and about leadership positions, but then you also have really great clinicians who also have their own niche too. Like you have Zaf Haseen, who's out at the University of Pennsylvania, who's like internationally known for his work in Reboa, which is very applicable to trauma. And so you can really just kind of go with it, find your niche, and then really do anything like within the health system that you want to do.
Yeah, no, that sounds like a great subspecialty of critical care, Dr. Hines. No, definitely appreciate it. Looks like Ben is currently applying. He's PGY4 at Curran Medical in SoCal. So look out for him when you see him applying to the specialty coming out.
Applications are, or this current cycle, I think, are due in 2 days. for
Yeah,
surgical critical care.
that's crazy. Perfect. Appreciate it, Dr. Hines. And if you would mind putting in your contact email, if you would be willing to, if anyone has any further questions to ask Dr. Hines about the surgical critical care kind of side, I know personally she's a very good contact to have. So again, thank you very much, Dr. Hines. All right, moving on to our next panelist. Next, I have Dr. Chukwuanu, who comes from, let me just see here really quick with my notes. He is Assistant Clinical Professor of Emergency Medicine and Critical Care Medicine, as well as an Associate Program Director of Emergency Medicine and Director of Emergency Ultrasound Division of Emergency Medicine, Division of Pulmonary, Critical Care, and Sleep Medicine at St. Louis University School of Medicine. Dr. Chukwuanu, do we have you on right now?
Yes.
Perfect. Very nice to meet you.
Nice to meet you as well.
Yes. Thank you very much for taking the time. Dr. Chukwuanu is currently at work and is just fitting us in so we can talk a little bit more about anesthesia critical care. So really appreciate it, Dr. Chukwuanu.
Yes. Nice to join you all.
Perfect. So just a quick question for you. So why did you choose the anesthesia critical care medicine route? Like what was that really kind of inspired you to go on to this field?
I think that when I was applying, it was right around the time when the pathways had opened up for critical care for EM training. And at that time, the first wave of graduates had kind of gone through the IM pathway, and there were some restrictions in the amount of fellows that the IM pathway could take at that time. This is around 2014-15. And I looked into the anesthesia pathway because it was available. It was other available option at that time, and it looked from the programs that I was looking at. It was multidisciplinary in terms of the types of ICUs that I'd be rotating in, the types of training that I was getting, and the type of attendings that I was going to be rotating with at the particular program that I went to and applied to. So I think that the training for me and surgical trauma medical training at that time, there may have not been a lot of multidisciplinary programs as much as there is now. And I think that's what kind of drew me to that pathway at that time.
Okay, yeah, no, this sounds like a very kind of, like I was telling Dr. Hines, a very expansive field where you kind of get a wide range of practice environments as well when you're delving into this fellowship and eventually practicing like you as an attending. Very exciting field, anesthesia critical care. But I'm also curious, a very common question, I guess, that would be asked is, what are some of the advantages and disadvantages of joining this kind of, I guess, fellowship as a future applicant or someone who actually practices in that field right now?
Yeah, I'll start with the advantages. The advantages to me is that the anesthesia and emergency medicine lifestyle is pretty similar. It's shift-based. So that was kind of understood. They were very accepting of trainees that were from other backgrounds, such as EM and surgery. A lot of the anesthesia programs take, OB-GYN as well too. So there's other people that come and do this, the fellowship through the anesthesia pathway. Like I said before, is multidisciplinary. They did a lot of work in cardiac anesthesia and translated over to cardiac critical care, ECMO, and neurosurgical critical care as well. So in trauma, because they were there, the trauma cases as well. So I think that was beneficial in terms of advantages. I think it was a lot of broad clinical experience in terms of the diversity of patients that I saw, and also the flexibility to actually practice some emergency medicine while I was doing that particular pathway. The disadvantages, I would say, is at the time coming out, the job market was a little bit difficult to navigate in terms of EM with its anesthesia training, and there not being that many at that time board certified or trained EM critical care doctors through that pathway. So there were some institutions that didn't really know what to do in terms of a contract, and I'm an academic, so trying to find a combined contract had been difficult. I think it's, as time has gone along, things are a little bit better, improving in terms of that nature. So a disadvantage may not be as much of a disadvantage. I think you'd have to really work to know exactly what your career goals are and where you want to be and what your objectives are, and plan this in advance. It's maybe a little bit easier from the internal medicine side, maybe a little bit easier from the surgical side, because not a lot of anesthesia groups are controlling critical care units in academic medicine as much anymore. It's a lot of IM and neuro and surgical. So anesthesia are like partners with those particular entities. Some groups will control, especially the cardiac critical care unit and some ECMO units. But to get a broad-based training and to practice in a broad-based, multidisciplinary manner, I think that you have to kind of plan that out. So that initially was a disadvantage.
Gotcha. So what I'm hearing is that there's a lot more advantages than there are disadvantages, which is a good thing, right?
Yeah, there's a lot more, definitely a lot more advantages in terms. I mean, that's you hit it right on the head. I mean, there's definitely a lot more advantages than disadvantages. The disadvantages only were in the job market after a fellowship. I think those have kind of gone away now, or not as serious as they were. But the advantages of training in any of the pathways, really, coming from an emergency medicine standpoint, you're going to be well trained from any program that you come out of. You're going to be taking care of patients with broad diversity and complexity and diagnoses and medical problems, and you're going to just translate that onto whatever critical care fellowship you do. But you kind of want it to model what you've done in emergency medicine, which is broad-based multidisciplinary training.
Absolutely. No, completely agree. So, and I think one of the hot topics that really, residents have, especially in 3-year programs, is the application timeline for anesthesia critical care, as well as neurosurgical critical care. How do you recommend a resident navigate something like that? Let's say they're in a 3-year program, they're going to be applying basically in their 2nd year of residency. What should they do to maybe beef up their application site or their application, or just make themselves a little bit more competitive compared to their, 4th-year colleagues or 4-year colleagues?
Yeah, if you're a student and you know that you want to do critical care and then you're matching into emergency medicine, you want to try to do your ICU rotations a little bit earlier. Maybe not the first rotation you do, so you want to get some emergency medicine skills under your belt, so that you can press people in the ICU. But maybe mid-year, you'd want to get your ICU rotations, the adult ICU rotations, in those months. I think that's getting an ICU rotation in the early part, first 6 months of your 2nd year, is helpful as well too, because you're going to be depending on these people for letters. And then getting involved in some research, even if it's case reports. Getting involved in some research early on, especially if it's something that you saw in the ED and went to the ICU, and you can kind of bring in both an EM and ICU attending or resident or fellow if you happen to be at an institution that has a fellowship. Getting that done early and on your CV will help you when you're applying. In terms of the application process, yes, it's very early, so you have to kind of know, and that's why I say, if you're doing the ICU rotations early on in your first and early in your 2nd year, you can kind of get your IM ICU rotation, your surgical ICU rotation, and any other ICU adult rotations you may have early, so you can kind of determine which pathway and which style you may like. A lot of times it's not about the actual pathway, it's about the program nowadays. And so, you could have broad training in IM and in anesthesia and surgical, just about the pathway. But finding that out early by doing your ICU months early will kind of give you a guide on which way to go. If you're doing the anesthesia pathway, of course, you're applying in your 2nd year, interviewing in the 2nd semester or the spring of your 2nd year with the match in the later part. I think it's in May of that 2nd year through a different system as well too. So you have to be wary of that, and you have to get your letters and talk to your program director very early on to be able to get rotations. If you can get an elective rotation in the ICU during your 2nd year, the later part of your 2nd year, that would be helpful as well too. But getting those experiences and getting those people on board, the people that you're going to work with, that you're going to get letters from, the experiences, your program director to also support you in this endeavor as well too, because you'll need a letter from them.
Yeah, absolutely. No, I love that perspective, Dr. Chukwuano. That's very good. Thank you. So last question from me is always my favorite one. What's your favorite part of the specialty? And what's your favorite area of, I guess, anesthesia critical care?
I think that, it's just how broad it is in the academic sense. How, you know, multidisciplinary for really seeing anything that comes in for an emergency medicine trained person. You know, surgical patients, trauma patients, I get to see a lot of different variety, similar to what we do in the ED every day. You know, you don't really know what's coming in, but you're going to be tasked with the managing the complexities of these patients and just the complex physiology and the complex pathophysiology of these patients that we're taking care of nowadays. Multiple medical problems, really sick, was always something that I desired to do since I was a medical student. And you know, that's what draws me. Teaching residents and fellows also draws me as well too. Medical students, and helping them see that EM critical care is the best specialty, the best pathway that you could do with your life. So I encourage people to take an interest in it, and try to get more and more people to see that it's a great pathway, it's a great lifestyle to combine both of these two specialties. You know, it's a young specialty, two specialties together, but it's a young specialty, EM critical care. There's definitely a path for you, whatever you want to do, be it research or program directorship, academic leadership, hospital leadership. There's definitely a path for you for whatever you want to do within emergency medicine and critical care.
Perfect. I appreciate it again, Dr. Chukwuano. Very good perspectives, and it's really nice to have you join us. So we'll let you get back to work. Definitely don't want to keep you too long. So thank you again, Dr. Chukwuano.
All right, take care. Good luck, everybody.
Okay, perfect. So we'll keep on pedaling along here. We're making pretty good time right now. So we'll move on to our next panelist, who is going to be Dr. Evie Marcolini. Dr. Marcolini, we have you on.
Hi.
There we go. Perfect. Awesome. So I'm just going to introduce you really quick here and say all the letters after your name and all that other fun stuff that goes along with it. So Dr. Marcolini is an associate medical director of ICUs, medical director of ECMO, Women's Hospital ICU lead, and founder and editor-in-chief of EM Coach. She's also a staff physician and at the rural ED. Oh, sorry, go ahead.
I think you're reading somebody else's.
Am I reading someone else's? I'm sorry.
I think you are.
Do you want to go ahead and introduce yourself, Dr. Marcolini? I apologize. I'm sorry.
I'm trying to figure out who you're reading, but I was like, oh.
I think you're reading Andrew Phillips.
Yeah, I think so too.
Like
it sounded
Andrew.
like his too.
Andrew's always here in spirit.
He is. I agree. Sorry. Go ahead, Dr. Marcolini.
No, no worries. So let me first say thank you for inviting me here, Matt. This is a great thing that you're doing. And I can't see how many people are actually on, but anybody who's on, please feel free to email me or anybody else on this webinar, because it's really important that we keep emergency medicine and critical care going. And I want to say, as the old person on this webinar, which I am going to say I am, I don't think there's anybody older on this than me, is that we didn't have these opportunities before 2012. And those of us who did fellowships before then, myself included, we did the fellowships and we knew that we couldn't board certify. And we were very skeptical. It was skeptical as to whether we could get jobs. You guys now have great opportunities, but you have great challenges because you have to choose. You have to choose whether you're going to do medical critical care, surgical, anesthesia, pediatrics, neurocritical care, which is the best. And there are challenges. We all need to work together as emergency medicine physicians and help each other. I have had many phone calls with people saying, I kind of need some guidance as to where to go. Please email me and we'll set up a phone call. I love talking to people about critical care. All that having been said, I was supposed to introduce myself, right? Which I'll do now.
That was a pretty good introduction too.
I'm Evie Marcolini. I trained in emergency medicine at Maine Medical Center. Then I did surgical critical care fellowship at Shock Trauma Center. I stayed there for 2 years working half and half EM and surgical critical care. Then I moved up to Yale, where I worked in surgical critical care, EM, and neurocritical care, where we were developing and building a neurocritical care dedicated unit. And I stayed there for 8 years. And then now I'm at Dartmouth, where we have just started a neurocritical care unit in 2019. And I am working half and half in neurocritical care and emergency medicine. And I'm also spending a lot of time working on ethics. I'm on the ethics committee and the ethics council team. So that's who I am.
Perfect. Thank you, Dr. Marcolini. It's very nice to have you here. Obviously, you're very well distinguished. No words need to say that. So again, it's just very nice to have you here. So talking about guidance, that's something that you're very passionate about. What is the pathway to neurocritical care? How would a resident or even a student who's considering it, how would they get to that point?
Yeah, that's a good question. First, just you're doing your emergency medicine residency. Somewhere along the line, you've decided, I really love critical care. The next thing you need to decide is, well, what flavor of critical care do I like? And we had Kene talking about anesthesia critical care. We had Ali talking about surgical critical care. Each different critical care has a different flavor. And you really, I would say, please do a rotation in each one and see what it's like, because it's a different flavor. I did surgical critical care as a fellowship, and then I worked as a surgical intensivist. And those patients are patients who have come out of surgery and they have a complication, or they're trauma patients and they have multiple, surgical complications, and you're managing them. And I can't really speak to anesthesia critical care, although most anesthesia critical care intensivists, I think, work in either a surgical ICU or they work in a neuro ICU, because I work with an anesthesia critical care intensivist here at Dartmouth. But when you talk about neurocritical care, for me, the difference is these patients are patients who were just like us yesterday, and today they have some kind of a devastating brain injury, whether it's a subarachnoid hemorrhage or a traumatic brain injury, if you're taking care of that, or a stroke, or some kind of CNS strange random injury, right? These patients were great yesterday, not good today. So what you're doing is you're trying to figure it out. It's really deep medicine in some cases, trying to figure out what is going on. But in other cases, it's taking care of the subarachnoid hemorrhage patient, which is the most fun, because they are so, in many cases, they're very labile, but they really need to be watched closely. And there are so many things that we do that change their outcome. But the thing that changes critical care medicine for me in the neurocritical care way, which convinced me to move from surgical critical care to neuro, is the families. The families who are there with the patients, who are there for days, weeks, and months. And the ability and the privilege to try to work with them, to bring them through this experience, is unbelievable. And I think that's kind of what brought me into the ethics world, because you really can have an impact on the families of these patients. Because if you think about it right now, we're all in good health right now. Tomorrow, any one of us can have a subarachnoid aneurysm rupture. We can have a TBI. We can have a stroke. We can have an ICH. It can happen. And who's going to take care of us? It's such an amazing privilege. And that's, to me, the difference from neuro ICU. But the other difference is the things that we do are really on the level of human laboratory. We do EEG. There are, when I was at Yale, they are now doing quad bolts, where they are monitoring the brain in 4 different ways and following it. And it's amazing. And we deal with people who have seizures and status epilepticus. We're differentiating anti-seizure medications. We are really looking at imaging. So imaging is a big part of our practice too. So it's really getting into depth into the brain, and it's fun. And the last thing I'll say, and I'm sorry, I'm going on, but Matt, I'll let you talk next. When you're a neurointensivist and an emergency physician, you bring the neuro stuff to the ED. I love working in the emergency department because there's so many opportunities to teach the emergency medicine residents things about neuro, which are not brain surgery or rocket science. They're basic stuff. And it's so much fun to teach residents how to differentiate the dizzy patient, how to learn about vestibular syndrome, how to read a CT, how to decide when you're going to order a CT, CTA, CT perfusion, MR. It's really fun. And you bring a lot to the emergency medicine world. I'm sorry, I'll shut up now.
No problem, Dr. Marcolini. I love your passion. You clearly love the job that you have. I love the transitions you've made in life as well, especially relating to the ethics side. And it's just a very unique pathway that you took. So we really appreciate having that conversation, that story that you just told us. To make a very, I guess, clear, or not a clear one, but a very kind of cut line question to come up next is, what are some of the, I guess, the skills and the talents that you need in order to be in the neurointensive care unit, or as a neurointensive practitioner? What do you need to have skills wise?
So to get into neurocritical care, to get into a fellowship, you need to be somebody who's detail oriented and have good follow through. It's really that simple. Follow every detail, and it's not hard. It's did you follow the details? And then digging into the story to try to figure out what happened before they got here, because so much of neurocritical care is about what was this patient before and how did they get here and how are we going to get them through. We work very closely with neurosurgeons, and especially interventional neurosurgeons and interventional neurologists. So it's very good to know how to read imaging, whether it's a CT, MRI, CT perfusion, all of that. It's really good to know that. Although you don't need to know that when you get into a fellowship, you will learn that there. But those are really good talents. Also, EEG is becoming such an important part of our practice. And in my emergency department, we have EEG at the bedside. So I, as an emergency physician, can order a 30-minute EEG in the ED. And it's good if you can look at that EEG and tell whether or not the patient is seizing. So basic EEG skills are pretty important. And, the other thing I would say is, know your anti-seizure meds. It's a wide panoply of meds, and there are many different, downsides and side effects, et cetera, of those. It's good to know that. Not that you need to know that to do the practice, because we always have consultants, we always have epileptologists, et cetera. But if you're going to practice in, let's say, a community ICU where you're doing mixed ICU, and I hope we're going to talk about that tonight, because many people will work in community ICUs, and you will take care of surgical, anesthesia, medical, and neurocritical care patients, all of it. And, knowing how to read an EEG is very useful.
Absolutely. Yeah, no, I love all of the advantages that you just said of neurocritical care. It sounds like a very great field to go into, and one to consider for a resident who loves kind of that neurosurgical side as they're kind of plugging along with their residency. But I guess another question that I'll pose to you is that I gave to Dr. Chukwuanu as well is, when a resident is considering applying to neurosurgical critical care, that application cycle looks fairly similar to anesthesia as well, where you have to start considering it early as a 3-year resident. Do you have any kind of advice that the resident should take, or a student should even take right now if they're interested in going into your field?
Yeah, I will say this, the application is probably going to be changing over time, because we have up until recently been UCNS, United Council of Neurological Subspecialties board certification driven. And we recently have become ABMS board certified, which is fantastic. Now we're in the big leagues, right? So what needs to happen though is the fellowships need to transition over to deciding whether they're going to be UCNS or ABMS or both. And part of that depends on the faculty. Are the faculty UCNS certified or ABMS certified? And there's a lot of, bureaucracy behind that. But it will change over time, and probably within the next 5 to 10 years, it'll Evie's guess is probably going to go toward ABMS, and that will be more standardized. But for right now, I think the most important thing to do, irrespective of where you end up, is you need to decide what you love. And it's not beneficial to just try to plug in and prove yourself in neurocritical care or prove yourself in medical before you've figured it out. Don't worry about that. If you have a passion and a desire, and you've done well in everything that you've done so far, I think you will end up in the right place. It's more important to decide where you want to be and make sure that that is the place you want to be. And I don't know how it could be other than neuro, because it's the best.
Absolutely, Dr. Marcolini. It's you're making it very easy for people to decide, I think. So you better be careful though, because a lot of people will start reaching out to you and asking for your advice, which I'm sure
Please
you'll
do.
love. So
Please do, yes.
Awesome. So just one of the last questions I have for you is kind of on the flip side of, in the institutional setting, do you see any difficulties for neurocritical care coming up, or anything that you're seeing that's happening now? Any advice and kind of, I guess, translucency with that?
Absolutely. And between you and me and whoever else is online here, it is a political quagmire right now. And here's why. Here's how it happens. Neuro ICU is relatively new on the block. So all of the patients with meningitis, subarachnoid hemorrhage were treated in the medical ICU for decades, forever, right? Because we didn't used to have neuro ICUs. The traumatic brain injury patients were treated in the SICU because they came along with probably multi-trauma. So that's the way it's been forever. Neurocritical care as a specialty is relatively new, and it's been proving itself with literature that shows that if you have a stroke, or if you have a subarachnoid hemorrhage, or whatever your neuro disaster is, if you're in a dedicated neuro ICU, then you do better. And let's not kid ourselves. It's not because of us. It's because of the nursing. It's because of the nurses' focus on the neuro exam and all of the things that we do for neuro patients. So it's developed along the way. When I was at Yale, we turned a neuro unit that wasn't really dedicated. It was run by pulmonologists. We turned it into a dedicated neuro ICU, which was run by neuro-intensivists, neurocritical care trained people. And it blossomed, and it started developing. Most ICUs in the country are community-based, and they are mixed ICUs. So when you get to the academic centers and the tertiary care centers, now we start differentiating. I'm at Dartmouth now. When I came to Dartmouth, we had just started the neuro ICU in 2019. And it wasn't without some pushback. Why? If you think about it, the MICU doesn't really want to give up their meningitis patients. The SICU really doesn't want to give up their traumatic brain injury patients. And so, by the way, they've been taking care of these patients forever. So who are we to come in and say we can do it better? And I will say this, there are many surgical intensivists and medical intensivists who do fantastic jobs at this. It's about the nursing. So it's a very delicate dance to develop a neuro ICU. You have to work within the institution, and you have to recognize why people might wait a minute. What that kind of similar to emergency medicine to get into critical care at all. People saying, well, you're emergency medicine. Why would you want to do this? So anyway, There are political issues, and you need to be a very diplomatic person. The best way to approach this is to be everything to everybody and to say, I'm here to help. And if your institution is starting a neuro ICU, you're not trying to take over anything else. You're just trying to be there to help. And those are the political, I'm being honest, those are the political issues that happen. But if you're in an institution that has developed a neuro ICU that has got the backing behind you, then sky's the limit, because there's a lot of really great things that can develop. And it starts slow. It starts with clinical care, developing the team, developing the nursing, and we really do need PAs and nurse practitioners. Then you get into research and other things. But it's a slow process. But that's one of the beauties of neurocritical care, is there's a lot of low-hanging fruit, because we are on the ground floor of developing something new, which is exciting.
Yeah, absolutely. Couldn't agree more. That is very exciting. And I think we all love the perspectives that you're giving as well, because you're being very honest, Dr. Marcolini, and I think everyone really appreciates that. It's not just all positives. There are definitely negatives to absolutely everything that we do. So thank you very much for telling us both.
This isn't recorded, is it? Just kidding. Just kidding. Just kidding.
No, it's not. Last question from me, and I think I already know the answer to this one, but like I asked everyone else, what's your favorite part of being in the neurocritical care unit?
My favorite part, hands down, is working with the families and helping them get through the experience. You know, most of our patients are intubated, comatose, and sedated, but the families are the ones who are living through it. And I really love working through that with the families. And let me just say, Matt, thank you. Thank you for inviting me. Thank you for having me. And thank you for introducing me as Andrew Phillips, because I could only hope to fill those large shoes.
Absolutely, that's right. Well, I think you're doing a pretty good job of that. So again, thank you very much, Dr. Marcolini. It's been very nice to hear you talk about the neurocritical care side, and just for the passionate talk as well.
Thanks.
Perfect. All right. So we'll keep on plugging along here. Okay. Next speaker that we're going to have is going to be Dr. Alexander Bracey. So hopefully I'm introducing Dr. Bracey right. If I'm not, hopefully he can cut me off and introduce himself. But Dr. Bracey is currently an assistant professor of emergency medicine at Albany Medical Center in Albany, New York. He's a graduate of the Advanced Resuscitation Training Program at Stony Brook University, and he is currently the fellowship director of the inaugural class of Resuscitation and Emergency Critical Care Fellowship. And his favorite hobby is backyard orcharding. Love it. Dr. Bracey, I'm going to give you the floor for a second.
Hey, thank you for, thanks so much for having me. I'm Alex Bracey, and you already introduced all the things that I think that are title-wise for me. And yeah, so I am of course representing a rather new discipline in resuscitation that is specific to the emergency department based critical care thing. In other words, I never leave the ICU. I never leave the emergency department to go to a different ICU. If there is an ED ICU, I like to think that I'm qualified to work there, and that would be the intent of the, or I guess the pinnacle of what I would be able to kind of contribute to a department in terms of ICU level care would be to staff one of those. And yeah, I certainly can explain more about resuscitation on in general if you prefer right now, or I can wait for questions, or however you'd like me to do this.
No problem, Dr. Bracey. I think it's just nice to have someone from resuscitation on here because it's such a new and expanding field. Hopefully we can get more interest, not from just the resident population, but also the students that are going to be kind of the ones that are up and coming and really taking hold of something that's hopefully more a little bit solidified, I guess, once they get to that point. But I guess the first question I have for you, Dr. Bracey, is why resuscitation versus a critical care medicine fellowship?
Yeah, no, that's a great question. I think that the biggest thing to ask oneself when, and this was a question that was asked of me and when I was in a resident looking at fellowship shoes, is do I ever want to leave the emergency department? And for me, the answer was no. I enjoy the emergency department setting. I enjoy the chaos. I enjoy the camaraderie. I enjoy the informal nature of whatever it is. But I still enjoy the critically ill patient. I still enjoy the critically ill patient, beyond including step one, but also including steps 2, 3, 4 even. I like being I like having the ability to see things for a critical care patient in the emergency department from an emergency physician only sort of perspective. I think it's staying in the emergency department only, being one full-time employee or FTE, sort of lends itself, I think, to having a perspective for what might be best for the patients as long as they are down in the emergency department. And let's be real, a lot of our critically ill patients are in the emergency department for a very extended duration, especially now, post-COVID, with all the problems that were, or continued COVID, post-acuity COVID, and with all the staffing issues that everyone's having. These patients aren't going anywhere, and they're lingering longer. There's more of them, and somebody's got to take care of them. And I think that we fill that role nicely. I guess the other highlight of what I think resuscitation brings to the table is the intent is to have mastery over the undifferentiated critically ill patient presenting to the emergency department. So where a lot of not all, but many ICU patients end up going to their destination ultimately differentiated. Again, that's not to say every single one of them, and certainly not in every setting, but a lot of the time they are differentiated in one way, shape, or form through testing and otherwise. But having a mastery over the first moments of a person who comes in looking like death and figuring out what the problem is, stabilizing with an element of mastery that might not be taught or acquired during a 3 or 4 year emergency medicine residency. That is what I think the primary mindset is of a resuscitationist.
Okay, yeah, I got you. And it sounds like, I mean, I love your passion for it. You clearly love the field that you're in right now, especially being in the ED and having that extra knowledge on top of it, again, to deal with the undifferentiated patient. Very exciting field to be in right now. I guess another question would be, what sorts of so let's say someone decided to do a fellowship in resuscitation. What can they do afterwards? Like, what would you say would be the opportunities they have?
Yeah, definitely. And this comes up a lot. And it's I think, Dr. Marcolini kind of, I think, referred to this in another context, when critical care was in its infancy as well, from an emergency medicine perspective. Resuscitation as a field is so new, and so there's a lot of questions as to what do you do? What do you bring to the table? At this point, there are 3 programs, including the Albany Medical Center program that's starting this year, that are quote unquote formal resuscitation fellowships. And I should clarify, when I say resuscitation fellowship, I mean not a clinically based one. There are research-based resuscitation fellowships that have been around for forever. And this is different than that, in that it's focused entirely, or almost entirely, around clinical care. So there are these 3 programs, and there's about 25 or 30-ish people that have completed one of these. The other one is obviously Stony Brook and Hartford have programs as well. And so graduates have gone on to do literally the gamut of emergency medicine. And so that's to say, they function in community settings well, again, caring for undifferentiated critical patients for whatever length of time they end up staying there. Community ends up oftentimes being a little bit more, expedient in getting patients out of the department. Not always the case, but sometimes. And to a good friend, colleague of mine is at one of the ivory towers of emergency medicine. And so the entire gamut is where seemingly we are fitting into. And I think that so the opportunities are there. I can only foresee them becoming more plentiful as time goes on, and the resuscitationist doesn't become like a question mark and becomes more of a known entity to what we bring to a department.
Yeah, exactly. That's right, for sure. And so I guess another question on top of that would be, do you see the graduates of resuscitation kind of easily fitting into the emergency departments in the future? I realize there's so few of you right now, but there's going to be more in the future, especially the way you're describing it. Do you see them fitting into more ER institutions and the institutions kind of accepting them with the training they've received?
Yeah, I don't think anybody that I'm in touch with just about all of them. It's just like it's such a small group right now, and nobody that I'm aware of is having like a hard time fitting into the department or finding their role, because depending upon where you practice, if you practice in Stony Brook, there's a resuscitation unit, and that's a pretty natural kind of fit. And any place that has split acuity, that is to say, they see like a high acuity zone or resuscitation zone, and then there's a lower acuity or a fast track and the like. This is a pretty natural fit for a resuscitationist to either staff that in large part or primarily. And so that's a nice place for resuscitations to go into. There are places that have mixed milieu. In fact, my own institution is mixed milieu, and we still find a role there. Ours being an academic institution, we have a critical care consult service that I help to staff. There's in the short to mid future vision of our department, there's an ED-ICU that's under development, and so again, that would be a natural place for us to staff in large part. And again, what's nice about having a resuscitationist in the emergency setting is that we all of our time is dedicated there. That's not to say that critical care, dual trained critical care folks can't dedicate all their time to it, but oftentimes they choose to work at least in part in ICUs, which is entirely understandable. But that is an advantage to our resuscitation fellows. We never leave. So and I guess the last thing I'll say about it is that even in places where maybe the training itself, for one reason or the other, they don't end up taking care of that many sick patients, or they don't end up seeing patients for an extended period of time if they're sick, and there's no boarding. This sounds like a magic place that maybe doesn't exist anymore, but if there is such an institution, then I think that the resuscitation fellows or graduates of resuscitation fellowships find themselves helping out with or finding their niche in things like quality improvement. For instance, airway becomes a natural place for us to lend our expertise in doing QI for things like that, making sure that first pass success is as good as it possibly could be, or infection rates for central line placements and things like that.
Yeah, great perspective, Dr. Bracey. I love it. So I guess two more questions for you. When it comes down to, your favorite portions of being a resuscitationist, can you narrow it down to just one, or do you have a couple that you would want to say?
Yeah, God, that's definitely a tough question, and I knew it was coming, and I've been thinking about it. I'm like, I still don't really know. The nice thing about it, I think, is one of the nicest things about it is I think that no matter what, I feel like I have a real role to play in any department, particularly mine. But that is to say, the clinical aspect of things, rightly or wrongly, I think I'm looked to as somebody who maybe knows, something about the first steps of care for a super sick person, or a cardiac arrest, or airway, or the like. But also, I have a heavy hand, I think, in the, maybe my residents don't like this, but I have a heavy hand in the residency with regards to their education. I have a niche to say, this is, how I would manage a critically ill patient in the emergency setting. And for the first day of their care, and then finally, it's such critical care in the emergency setting is still such a place that there's so much possible research that's left to be done, and I find myself kind of exhilarated at that ideal. Once I have to get myself established a little bit more here, and put one foot in front of the other, as it were, but. It's such a rich vein for research it's all very exciting, I guess is the point. I guess the last thing I'll say about this question, it's such a good one, is beyond, doing all the fun stuff and seeing patients, through their first, 24 hours of illness. One of the, I think the most meaningful things of my training was, and I think of resuscitation training in general, is the end of life discussions. I think that that's a major portion of our training, and being able to have tactful, skill, directed, dignified conversations, and sparing patients ever having to go to an ICU if they would not want it, and allowing them to pass with dignity in the initial moments of their hospitalization, if that is clear what is needed. That's undoubtedly one of the most gratifying, emotional but gratifying things that I think that we can do, that I feel like I do on a daily basis.
Yeah, absolutely, Dr. Bracey. It's really nice to hear this, because it's really the forefront of a new specialty right now. We're getting to hear all about it from someone who's obviously very excited about this. So again, really appreciate it, Dr. Bracey. Last question from me is just, you had mentioned that there's 3 fellowship opportunities throughout the United States for a resuscitation fellowship itself. Do you have any, I guess, recommendations for residents or students who are looking into resuscitation application wise? Do you know when they should apply for it, letters, or what else makes them stand out for your field?
Yeah, sure. The biggest thing that I can advise a prospective resus fellow to do would be, again, the biggest question I think every place would ask would be like, do you ever see yourself practicing in an ICU that's not in the emergency department? And if the answer to that is yes, it's not the right thing to do. So if you have overcome that hurdle, I would say to make a competitive applicant, I think in essence, look for the sick patients in your department, run at those, make it known that you're interested in those in the care of those patients, and then I think that will show up in any letters that are generated on the applicant's behalf. And then as far as timing goes, I think all 3 make their decision by October. So reaching out as soon as is probably the easiest way of doing it. As far as formal application cycles go, I mean, we're not ABMS, and so nothing's particularly formal. And so reaching out to the fellowship directors is probably the best way to do it. At Stony Brook, it's Brian Wright, myself at Albany, and then it's Matt Tischauer and Christina Liu over at Hartford. My buddy Dan Patino is put his information in the chat, and he completed his fellowship over at Hartford. I'm sure he'd be happy to talk about it and have those contact informations as well.
Absolutely. Appreciate having both Dr. Patino and you, Dr. Bracey, on here to discuss this up and coming field. So yeah, very exciting to hear your guys' perspectives as well. So awesome. That's all the questions I have for you, Dr. Bracey. Thank you very much.
Thanks for your time.
All right, we're going to keep on plugging along here. Last but not least, of course, we have Dr. June Gordon, who also sits as the CCMS chair for AAEM. So I'm just going to quickly introduce Dr. June Gordon, and we'll give her the floor. So she is currently an assistant professor of emergency medicine at Stanford, where she did her EM residency and critical care medicine fellowship. She works in the MS-ICU and the ED-ICU, and she's also APD of the Critical Care Medicine Fellowship. And again, this is chair of the AAEM CCMS. Dr. June Gordon. Dr. Gordon, thank you very much for coming, and thank you for giving me a little bit of your time.
Always. Thanks for having me.
Awesome. So we're going to delve right into it. So I guess my first question for you is going to be, why do a fellowship in critical care medicine?
Ooh, that's a good one. I think Evie and I are aligned in our feeling that what we do is the best job ever. We only disagree slightly, and that I think it's critical care medicine and she thinks that it's neurocritical care, but actually, honestly, they're both so good that I think either one is fine. I think that what we do is just really tremendous. Training in emergency medicine is wonderful training for critical care, and being able to take care of critically ill patients is really a gift. And I think that's why you should do a critical care medicine fellowship. I think, answering the subcategory of that question, which is why critical care medicine as opposed to the other specialties that you've heard about. And the honest answer is you should really do any of them because they're all great. The specifics about critical care medicine, I think if the medical patient population is what fascinates you, the complexity of those patients, if you want to work in a MICU or an MSICU, those are reasons to do a critical care medicine pathway. I also think our fellowship allows for a lot of scholarship. And so if you think that you want to have an academic job, then a critical care medicine fellowship is really tailored to create academicians as alongside really expert clinicians.
Yeah, absolutely. So where do you currently practice? What's the environment that you practice in right now, Dr. Gordon? And what's the reason that you're there personally?
So I'm there because they'll have me. But I work in I have basically two different clinical jobs. So one is I attend in our MSICU, and that is exactly what you'd expect at Stanford. It's a big M, little s ICU. So it's largely a MICU, but we take care of some surgical subspecialty patients. There's also a SICU, and the SICU is really general surgery, trauma, and surgical subspecialties of general surgery. So it's largely a MICU, and that is exactly what you would expect of an academic ICU. So there I work, someone was asking about time. I work a week at a time. There we have a team where I have a fellow residents and medical students with me. Then my other role is we have an ED ICU where between 2 and midnight, I now can say we have a dual boarded EM intensivist. I used to not say that because I was the only one who hadn't taken my boards yet, but now we've all been dual boarded in emergency medicine and critical care. And we are there from 2 to midnight, Monday through Friday. We go where the patients are. So we essentially function as the swing ICU attending. So we take care of all of the already admitted ICU patients. And then we staff new admissions. So any new admission between 2 and midnight. And the ED can call us as a consult for critically ill patients. We don't see any critically ill patients primarily in the ED, which is different for our ED ICU model. But so that's my other clinical role.
Perfect. No, I knew you were going to give a good perspective on that, Dr. Gordon. So thank you for that. I guess one of the questions that always comes up is, I guess MICU or the CCM fellowship from emergency medicine has been around for a while in quotation marks, right? Do you see this expanding anywhere right now, or do you just find it's kind of just remaining baseline for those that are practicing in it?
Yeah, so I think you heard from someone earlier that there used to be a cap on how many EM applicants we could take in the medicine pathway. And since that cap has gone, I think we're having more and more EM applicants. And we actually see that some of our strongest applicants are EM applicants year over year. I think there are some specific reasons for that. So I think it is certainly expanding. And as Evie said, this is a time where you can actually get a job as an EM intensivist, right? Which is really remarkable. So not only can you do a fellowship, not only can you now get boarded, but you can also get a job. And I think that we are really uniquely suited for this specialty. And so I think it will certainly continue to grow.
Yeah, absolutely. I got a comment on your ring really quick. It's very beautiful.
Oh, thank you. I'll tell my husband you.
Perfect. So last question for me, Dr. Gordon, just like I did for everyone else. What's your favorite part of the specialty you're in right now?
I think I have two favorites.
Okay,
so
we'll
one
allow
is
this
working,
time.
Okay, thank you. One is working with our fellows. We have truly remarkable fellows, and I am lucky that I get to work with the critical care medicine fellows, the critical care anesthesia fellows, our neurocritical care fellows, our surgical critical care fellows. And so that is a true joy. Our fellows are so smart. They work so hard. They're so dedicated. They're such lovely human beings that being able to come to work and work with them is really, really a true pleasure. So that's one. And then the second thing is getting to take care of the critically ill. These patients are fascinating, they're complex, they're dynamic. And I feel like the fact that I have the skills to do it is really a gift. And the fact that I get to do something that I'm skilled at and that I enjoy is really lucky and special.
Yeah, absolutely. Couldn't agree more. So I lied. We do have a little bit more time. So I'm going to ask you one more question, if that's okay.
No problem. Of course.
So when it comes to application advice for the residents that are considering critical care medicine, what I guess, is there anything unique to the critical care medicine field that they would need to kind of delve into that you would want to see as an APD that would make them more competitive for the field?
I don't think so. I think we want to see someone who has dedicated time and energy to critical care, someone who really wants to do this, someone who has really strong letters, and has, an attempt at scholarship in the field. But really, we want lovely people who have done good work. That's the most important thing to us. And so if that sounds like you, apply.
Perfect. Appreciate it, Dr. Gordon. As always, this is probably your 3rd or 4th or 10th webinar that you've done. So appreciate it as always. Awesome. So I think that's all we have for all of our, I guess, panelists that we have here. I'm just going to do a quick preamble or postamble or whatever that's called now, and then we can get to some questions as well. Okay, if there are any questions out there. So just again, there's future critical care medicine section events that we do have going on. We always host our monthly council membership meetings. They're always on the first Thursdays at 5 p.m. Pacific time, 8 p.m. Eastern time. And you can apply for the, I guess, the My AAEM emails, and they'll send you or Kathy, who I have forgot to mention. Kathy is amazing. She's director of AAEM, and she has done an amazing job of not only helping us at CCMS, but AAEM as a whole. She is amazing, and she's also here right now. So shout out to Kathy. But she will be the one who sends the Zoom link off to you guys, and you're more than welcome to join the CCMS talks at any point. We love to have people join in the conversation. If you don't receive the My AAEM emails, then please contact Kathy at AAEM, and her email is kuy@aem.org. CCMS AAEM members automatically receive the invitation as well. If you aren't a member of the section, then please join. That's what we want, right? We want more and more members as we can get. And then also, if you have any ideas on topics that you want to see, or anything you feel that the critical care medicine section should kind of bring forward, please don't hesitate to reach out to any of us. I'm more than happy to receive any emails at all, and just very excited to get things to keep things going. So some of the things that we do have coming up right away is going to be the CCMS's Breviloquent Junior Speaker Competition. And then we're also going to be having a fall salon, but much, much more to come as well. So thank you for joining us tonight. And we definitely look forward to seeing you soon again. And I'm going to leave it off to any questions that the current people that are in here in the room have. Please, more than happy to get some of the panelists to hopefully answer some of the questions. I was always told to give it an awkward 10 seconds. And if there wasn't any questions in 10 seconds, there probably is not going to be. If you do have any questions in the future for any of our panelists, I believe they put their emails into the chat for you guys, which thank you very much for doing that, guys. And they'll be more than happy to answer anything. So, yep, thank you very much again for joining us, guys. Really enjoyed having all the panelists here. Thank you to the panelists, of course, as well. It's so rare to get all of you guys together all in one place to give a really good perspective on each of your specialties. So thank you, thank you, thank you. And
Matthew,
that will be.
We have one chat. We have one question in the Q&A.
Absolutely.
Which I think probably is for me to answer.
Sure. Yeah, please, Dr. Gordon.
So Armin asks, how important is it to have the 6 months of IM training before applying to medicine critical care? So that, just so you know, any subspecialty of internal medicine, so cardiology will count as that, any like a CCU will count. So any medicine, anything in the house of medicine will count towards that. And I would say that's very specific to your program. Many are flexible with that number and wouldn't say don't apply. We'll just work to get you your appropriate months when you get to us.
Perfect. Thank you, Dr. Gordon. Hopefully that answers your question, Armin. If there aren't any more questions, then I will, let me see here. Community ICU realm be addressed? Yes. Does any of the panelists have a good perspective on the community ICU realm?
Actually, that's actually what I started off doing is community ICU. And so I was doing academic EM, but doing community ICU. So I was part-time in academic EM. And then community ICU. That's actually where where I'm sitting at right now, is in a community ICU. So it's a mixed ICU. That's why I kind of chose the pathway and kind of harping on the multidisciplinary training. I did, I'm now in it's a medical, surgical, trauma, and a neuro ICU, kind of split. We have about 30 beds, 34 beds that we cover. Probably about, the census is probably about 28. And yeah, it's just it's a great way for me to keep my skills in critical care. I love practicing outside of the academic realm. And when I was starting off out of fellowship, I really wanted to do some intensive critical care that wasn't necessarily dominated by fellows and residents. And so it allowed me to really take care of sick patients. They're just about as sick as the medical center, the big medical center here that we're a level 2 center, right outside, affiliated with my university hospital. And yeah, I can take any other questions about that.
Kenny, I would corroborate what you're saying, because when I was my first year out after fellowship, we contracted out to a community ICU, and I got to do so much more medicine myself, because you're it, right? And it's a very different relationship that you have with the physicians on staff. It's a very different relationship that you have with the hospital. And it's a great experience. And you really need to know everything: medical, surgical, neuro, everything. It's a wonderful experience. Yeah.
Wonderful. Thank you for the perspective, both. It's yeah, community ICU setting sounds like a very exciting area to be in, just because, like you said, Dr. Marcolini, it's you get to practice all the different types of ICU, which is exciting too. Perfect. So do we see any other questions in the chat before I cut someone off again? Perfect. Okay. So as Kathy reminded me very politely, do any of the panelists have any last things they would like to say before we end?
I think I'll just say, please come to our critical care medicine section meetings. There's lots of opportunities for students and residents and fellows to get involved. Lots of easy things to add to your application, and a great way to show interest. And also, we just love having you there. And we usually have some fun. So come join us.
I'll say thank you, Matt, and thank you, June, for putting this together. And thank you, Kathy. I know it's a lot of work to put something like this together, and I really appreciate it. And I know that the people who are on, who I can't see, appreciate it as well. And please, please use my email. And Alex, I love, where'd your baby go?
She's around here somewhere.
As always, thank you so much, Kathy. We could not do anything without Kathy.
Nothing.
And thank you, Matt.
No problem. Absolutely. So yes, thank you, Dr. Bracey, as well, for introducing kind of, I guess, the new future EM physician as well. It's really nice to get the perspectives on the up and coming specialty for sure. So if there's no more last minute words, no more last minute questions, again, before I cut anyone off, then we will end the webinar here. And I really appreciate all the panelists being here and all the participants, of course, asking the questions. And hopefully that gave you a better perspective of all the different critical care specialties that are out there. And each one of them has their own little niche, and each one is just as exciting as the other. So really looking forward to seeing you guys in the future. And any questions, please reach out to any of the panelists or myself. So otherwise, have a good night. And thank you very much for coming to our webinar.